In our final episode, we're going to recap your journey to your best heart health. So, stay tuned. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Hi, I'm Dr. Warwick Bishop and I'd like to welcome you back to our last episode of our Healthy Heart Network series. I'm going to recap from the beginning just to refresh your memory. Our story started with the fun runner back in 2005, a man I'd seen 18 months earlier and had reassured that he was fine, only to be involved in his resuscitation by the roadside. He's a reminder of how you can look well on the outside, but not necessarily be healthy on the inside. We went on and talked about the structure of the heart, how the heart has an electrical system used for acceleration and deceleration and coordination of contraction of the heart. We talked about the pistons and valves, the muscular chamber of the heart that squeezes blood, and the one-way valves to stop the blood flowing back. Importantly, we also talked about the fuel lines and the importance of those three major fuel lines which supply blood to the muscle of the heart. We discussed primary prevention, stopping an event occurring, and we talked about secondary prevention, stopping people having a second event. Importantly, we covered the limitation of risk calculation in primary prevention, and we started to understand that the rate of an event in a population can be quite different to the actual event that an individual has. An individual's actuality will be 0% or 100%, no event or an event. We talked about how the chance to be more precise by using modern imaging techniques can be used to improve our risk assessment and then our management strategies. Importantly, as we started to understand our current risk tools and the difference between population and individual risk assessment, we started to understand where there were pros and cons in the current way that we do things. We started to introduce how we can bring imaging of the heart to look at the health of the arteries into a decision-making or management strategy for an individual patient's care. We started to consider who may benefit from this sort of testing, looking at the arteries and being clearest about exactly what to do for that person. It may be people with high cholesterol. It may be people with a bad family history of heart disease. Patients who have an intolerance to the medications used to lower cholesterol. But also it could be for people who have a desire to be proactive about their own health issues and want to be ahead of the game. We talked about, if you did get a scan, how to start to interpret those results. What calcium in the arteries means, both in absolute terms and in percentile terms. We also talked about build-up of cholesterol in the arteries and how to make sense of some of those findings. And I talked about a paper I'd written called the C+ paper, looking at all aspects of potential risk within a heart scan so that that can be formulated and brought to your best care. We talked about chest pain. We talked about symptoms and prognosis. We talked about management of heart disease using pharmacological therapy, things that stabilise plaque, but also things to keep the blood thin so clots don't form within the arteries and cause sudden blockages. We touched on stents and we touched on coronary artery bypass grafting, ways that we can get more blood to the heart if required. And we talked a little bit about who that would be for and why. I was absolutely delighted and privileged to have had the opportunity to speak with Professor Matt Budoff, a world leader in imaging and cardiovascular disease prevention. And you'll also remember we had a terrific chat with Danielle Toscan, an accredited practicing dietitian who gave us some great information about heart health and eating options. But what has it all been for? This series has been about educating and informing individuals. You. Why? Well, my experience is that not all patients get the information they want, or perhaps aren't necessarily satisfied with the information they are given from either their doctor, that they get from the internet, or from well-meaning friends. The internet, of course, has no filter on it, so you don't know the relevance of that information to you. Even if you had a medical degree, how do you bring all that information together without any medical experience? In this particular field of imaging and risk, things are changing rapidly, and it's very hard, even for practitioners keeping right up to the game, to manage to stay abreast of all those changes. Right at the moment, our technology has moved very rapidly. Just have a quick look at your mobile phone if you don't believe me. When it comes to imaging the heart, the technology has moved rapidly down the road. Our guidelines, which are informed by studies, are taking a while to keep up with that because of the requirement of randomised controlled trials to inform those guidelines. And of course, some doctors have trouble keeping up with the guidelines, so there is a gap between what's available and what many people are getting. And my series has been designed and dedicated to try and give you the opportunity to fill that gap. My hope is to empower people like you, to have the knowledge they need to ask the questions they need from their health providers to make sure they get the very best care because they've had the very best conversations. I strongly believe that the best educated patients get the best health care. I created the Healthy Heart Network to educate and inform patients to help them be part of their best healthcare journey. Stay tuned for a review of this series' cases. Well, I hope you enjoyed the refresher on the teaching that you've just had. I'd like to come back and run you through the cases that we've shared through this whole series. Let's start with Simon, the 42-year-old smoking judo competitor who didn't want to be told to give up the cigarettes. He had a positive family history, but we clearly showed problems which indicated that he could well have gone down the path of his other family members. He did make some changes based on the information we were able to share with him, and he is still doing well. We also talked about Mary in her pink jumpsuit and her first grandchild. She had chest pain symptoms. We clearly showed that there was a problem with her arteries on CT imaging and proceeded on to appropriate investigation and subsequent revascularisation, which is a word we use for opening up the artery. She's had more grandchildren since and is doing really well. We talked about Mark, the endurance athlete who turned up out of curiosity, and perhaps thankfully so. Look what we saw in his arteries. This was a man who was fit and strong, and on the outside to all the world looked a picture of health, but his arteries didn't. We now have him on the right therapy. He is much safer knowing what's actually going on in his arteries. We've taken his risk from here to here. He's tolerating his medications. He continues to participate actively and enthusiastically in a wide range of sports, and delighted to know that we've been able to make a real difference to his potential future. We talked about Mick, the 50-year-old man who had the rhythm disturbance, the atrial fibrillation. He wasn't really looking after himself. We decided to scan his heart just to see what was going on. We found a little bit of calcification, but we found some nasty plaque at the very beginning of a large artery. This was a nidus or a catalyst for us to put in place some real lifestyle change, some interventions that were going to make a difference for him and reduce his risk of heart attack into the future so that he doesn't suffer the same problem as the person who that ambulance is racing to right now. We also talked about Alan, a 76-year-old farmer. This was his risk profile, not particularly compelling or concerning, only had a yellow thermometer. He was pretty keen not to be on medications, but we did scan him and we found he had a lot of rust in the pipes, a heap of calcium. In fact, more than 90 men the same age would have if we took 100 men randomly off the street. He's now on appropriate therapy, still chasing sheep and still selling hay. We learned a little bit about the broken heart syndrome. This is what the ECG looked like. It's called Takotsubo syndrome. You can see these ECG changes. We talked about those as we went through. This was the heart and how it worked. Heart not working properly here. And then weeks later, you can see this area now working properly. An interesting case and a reminder that you really can have a broken heart. And just a reminder that with this condition, we need to show that the arteries don't have any blockages which are causing the abnormality of function. We talked about Peter, the 60-year-old male, who wanted to know what his risk of an event was because he didn't want to pay his insurance premium. This was his lipid profile. We saw his sugars were up a little bit, but all pretty unremarkable and not really a high risk sort of guy. We did scan him. He didn't have a particularly high score, only 72, but he only had one plaque, and that one plaque was in a very major artery. One that if it blocked off would have been the end of Peter. That gave us the opportunity to make some changes, to put in place a strategy, and for Peter to be part of that modification and lifestyle adjustment to reduce his risk into the future. His glucose came down, his lipid profile looked better, and a year later, the calcium in his heart had barely changed, a very reassuring finding. We talked about Bob, the geologist, who wanted to know what was going on with his arteries because he travelled to far-flung places and he had a couple of kids at home who he wanted to make sure he was there for. I think you can see really clearly that he had plaque. And that particular lesion, narrowing the artery as it is, with its component that's non-calcific, you can see it there, was enough for us to make a decision that his risk, left unattended, would be unacceptably high. Bob continues to travel the world with his medications. We also talked about the incidental finding of calcium on a CT of the chest for other purposes. And this was Pam, remember? We saw a fleck of calcium when we were looking for rib pain. This is what that fleck of calcium represented, a significant narrowing in the beginning parts of a major artery in her heart, an opportunity to change her future by putting in place appropriate strategies to stabilise that plaque and reduce the risk of clot forming there. With Bill, we also found, incidentally, something that needed action outside of his heart. We fixed his heart, but we were also able to save his life by turning up a primary tumour of the lung that was resected, and years later he remained symptom-free and well. We also talked about Steve, a 28-year-old fisherman who presented with chest pain but had a negative stress test. He had a CT coronary angiogram which clearly showed that he had plaque right at the beginning of the left anterior descending artery, one of the major arteries in the heart. But that plaque was not causing any narrowing whatsoever. The plaque had literally grown out into the wall, not causing any impact on the lumen, and was not seen at all by the invasive coronary angiogram. A reminder that just looking at the inside of the artery doesn't always tell us about the health of the wall of the artery. And that's because of this process of remodelling, where cholesterol can build up in the wall of the artery, and the artery changes shape to keep the size of the internal diameter exactly the same, in spite of this build-up. This is a concerning feature and one we really have to be aware of if we're going to make the best decisions about reducing risk of an individual into the future. Another example of plaque, but no indication of narrowing in the arteries. I just can't emphasise enough the importance of understanding the process of what goes on in your arteries. The arteries can be opened, allowing blood through, but if there's rust forming in the pipes, we need to know. And you just don't know till you look. The cases we've shown prove that you can look well on the outside, but not necessarily on the inside. Our cases also remind us that stress testing is great for assessing symptoms and tells us if there's a narrowing or not, but doesn't tell us the health of the arteries. Cardiac CT can give us a real opportunity to appreciate the state of the arteries and with that knowledge make the best decision for the future care of you, the patient. I hope these cases connected with you or reminded you of someone you love and give you the impetus, the drive and the confidence to go and have the conversations you need with your healthcare professionals to get in place the treatment you require to reduce your risk of heart attack into the future. Stay tuned for our wrap-up patient question. Welcome back. In this last patient question section, I'm going to answer a question that I've been asked over and over through the years, and that is, how did I end up as a cardiologist? Well, truth be told, I ended up as a cardiologist by chance. As a young fellow at high school, I was okay at maths and technical drawing and physics and chemistry, and I thought I'd be an engineer. Well, as fate would have it, I had the chance to do some work experience at a local civil engineering company. Not understanding what civil engineering was, over the next couple of weeks I observed a lot of office-based work focused mainly on drawing retaining walls and draining systems, and I have to say, it didn't really grab me. Unfortunately, I don't think that was a fair representation of the breadth and interest that engineering could offer, but I didn't know that, and I was no longer enthusiastic about pursuing engineering as a career. Because of my science background, I thought I'd apply for medicine and was somewhat surprised when I was subsequently accepted. There's no question that the medical degree was an interesting and challenging one, and through the years I found myself drawn to the processes of internal medicine more so than the skills of surgery. When I eventually finished my internship in junior years, I looked to training. I started in different areas of internal medicine and found that although I had an enthusiasm for haematology, the study of blood disorders, the fact that I was colourblind meant that I couldn't appreciate the special stains and colours that were used and were required for diagnosis as seen under a microscope. So I put haematology aside. My time subsequently was spent in gastroenterology, the gullet, respiratory, lungs, rheumatology, joints, oncology, which is cancer, and renal medicine, and for various reasons these specialties just didn't sit with me either. I eventually dropped into cardiology, more by good luck than good management. As it turned out, at the time, cardiology was a dynamic area. This was the era of clot-busting medicines injected in the arm to stop people in the midst of a heart attack. It was a very exciting place to be. Bypass surgery was available, and ballooning of tight arteries, which subsequently became ballooning and stenting of tight arteries, was starting to appear on the horizon. At the same time, very exciting trials looking at cardiac failure, and overall cardiology was a really exciting and interesting space to be. Over the years as a trainee, I learnt about diseases, but subsequently, as a specialist, I started to learn about people. It has been a tremendous realisation that within the realm of my profession, I'm able to make a real and meaningful difference in people's lives on a daily basis. I'm always grateful for the opportunity to have time with students and junior doctors, and I particularly try to make a point of sharing with them what I have found from sitting in my consulting room, rather than what I've found from the books. The most important points that I share with these young and upcoming doctors are the three following. First of all, people don't care how much you know until they know how much you care. So as part of a consultation and management strategy, there's a requirement to engage with the patient in a way that makes them realise that they are not just a disease, but an individual who needs help and care. I've always said that the job is a privilege in so many ways. We need to be careful not to take the job for granted. In our office, people we have never met will often share things with us that they wouldn't share with anyone else. We have the opportunity to truly make a difference in their lives, for better or for worse, and we need to be aware of the implication and that responsibility. Doctors are often given respect, often without question, and to not treat that with care is an embarrassment to the entire profession. It's not uncommon that the doctors in the hospital get the best car parks and may even get free coffees from the coffee shop. These privileges need to be recognised, and we need to be humble in accepting them. Not to do so is arrogance. Lastly, it's important to go the extra mile. Often it's the case that whatever the patient's actual presenting problem is, it may not necessarily fall within cardiology. If that is the case, I would see it as my role, not to simply end the consultation and send the patient away, but to genuinely try and find the next step toward what is required for that individual to have their particular needs sorted out. It is a professionalism that dictates that we need to, as best as possible, be holistic in our care and do whatever we can in our means to make sure that we're responsible until we have found another responsible professional to pick up the baton for that individual patient. Personally, in going the extra mile, I've written a book. This was born out of a realisation that there is an important conversation that needs to be had within the community around the role of cardiac CT imaging for cardiovascular disease prevention. Currently, the information is broadly limited and the application of the technology is therefore limited also. This opportunity, however, is enormous, and so I've written a book to try and educate the public so that they may have an informed and meaningful conversation with their own doctor about their own health and be proactive for their own best care. There is no question that from time to time the job has been hard work, demanding, stressful. However, on balance, I couldn't see myself doing anything else. Well, that concludes this series. I really thank you for joining me. I hope you feel educated and informed. Wishing you good health, and please don't die of a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover, a paperback, and an audio from Amazon, or wherever good books are sold.